Hello and welcome to the Do More Foundation podcast. We're in season 2. I can't believe that. So exciting. And we're doing a roaming mic series with microphones that are finding their ways to interesting people and experts in their field, so that we at the Do More Foundation can have conversations with the experts around matters, best practice, and important issues that our young children in our country are facing. Welcome to Anna-Marie Müller. She's our guest today. I'm so excited to have you, Anna-Marie, because, for a number of reasons, but top of mind is the fact that we both share such a passion for young children and nutrition. So I'm looking forward to our interesting conversation today. Welcome.
Thanks very much, and thanks for the invitation. I'm very pleased to be here.
So the Do More Foundation has a bit of a tradition going with our podcasts where we start the podcast with something fun. So I'm going to give you a fun tongue twister for your morning.
Okay.
Here we go. Pick a picky pickle pack packed with peppy purple snacks. If the picky pickle pack lacks, pick plump peppers and pile them back.
Pick a picky pickle pack packed with peppy purple snacks. If the picky pickle pack lacks, pick plump peppers, pile them back.
Amazing. So if we ever get queried, if we take ourselves too seriously, this is reference. Let the record state that we too can play. Anyway, thanks so much for playing. And welcome to the podcast. Today we're talking about young children, nutrition, and all the issues that come into this vast field that is sometimes quite scientific and sometimes it's not. And so that's really where we're picking up today. You've dedicated your career to tackling children and malnutrition. Maybe you can introduce yourselves to our listeners and share a little bit about how you became interested in nutrition and food systems.
The two are so linked. So at the moment, I work for GrowGreat, which is a national zero stunting campaign. And I've had a toe in the water with GrowGreat for a very long time. When I finished a master's thesis in 2015, I think, the DG Murray Trust was just starting to think about how to tackle stunting from what they can achieve with their funding. And I was invited to one of the first meetings before GrowGreat was called GrowGreat, just a meeting around a board table about how we can address this problem in South Africa. And so that was kind of my introduction to this organization, which now is many years old and has really rich implementation experience. And at the moment, I'm leading the monitoring, evaluation, and learning unit. And it's been just incredible for me to be so embedded in this organization and having that perspective of where it started as just a conversation and now a fully fledged organization with a fairly large staff complement and a national footprint. It's really fantastic to be able to have been part of that journey in many different ways. And so the reason why I was invited to that first conversation is because my master's thesis was on strategies to eradicate stunting in South Africa. And so at the time, it wasn't a topic that was published, that there were many publications about. It was kind of, stunting was part of the malnutrition story, but didn't have the kind of specific emphasis that I think it's achieved over the last 10 years. So I was there at that kind of early stage of it. And I wrote up a case study of the leadership approach of the nutrition director in KwaZulu-Natal, because there'd just been a big report on why stunting rates were falling more rapidly in KwaZulu-Natal than anywhere else. And I thought, that's worth investigating. What are the enabling factors that are making that happen? And I was convinced, and I think my research showed that the leadership approach of Lenore Spies, who was the nutrition director at the time, really made a huge impact, and the kind of accountability culture that she created there around malnutrition and stunting in particular, I think was really pivotal. And it definitely shaped the conversation since about who the relevant role players are and what is the transformation that we can see when there's high-level political buy-in, so that nutrition issues don't remain kind of embedded in the Department of Health. But I remember very clearly her saying to me that they have these war room meetings in KwaZulu-Natal hosted by the Premier. And even if she were absent, malnutrition would be on the agenda. And I thought that was so powerful that, you know, you didn't need the champion in the room, but the message and the importance of nutrition had landed in that group of people so much that it could be discussed and strategized around, even in the absence of the typical custodian, which is the Department of Health.
Yes. Wow. Also just such a clear message that nutrition is not only a Department of Health issue, but that it can go way beyond that. And I'm excited to explore some of those ideas with you in this discussion. I mean, South Africa has made some strides towards tackling malnutrition. And yet we have this thing of stunting that keeps popping up, this question of what is stunting. I think that comes up more often than not. What does the data tell us? Where are we sitting today?
So for the longest time, we were having this conversation in relation to 2016 data, which is when the last demographic and health survey was completed. But then last year, new data was published that was commissioned by the Department of Agriculture, Land Reform and Rural Development. And the research was conducted by a team out of the Human Sciences Research Council, the HSRC. And this survey, which is the Food Security and Nutrition Survey, it found an increase in stunting levels. And this caused quite a lot of concern for those of us who are in the field, and also asked some questions about why is it that this, although the levels have been fairly stable since the 1990s, there was a little bit of a downward trend that we were seeing. And why suddenly this spike? And so it even caught the attention of the WHO. And as far as I know, that whole research report is under review by the WHO. So I recognize that this report echoes the message that stunting is still a problem. I'm not convinced that we've really had a decent enough look yet at the methodology to be sure of the rigor of their findings. So that's the position that I have at the moment, based on many discussions with really the kind of leading thinkers in the academic world around stunting in South Africa, is that I withhold my final opinion on those findings. Especially because there have been other surveys that were done since 2016 that pointed in a different direction. And so what do you do when you have these this convergence, or divergence rather, where you've got data that are pointing into very different directions? So I think what we can say from a report like this is that there is still a significant issue with malnutrition. There's definitely an issue with food insecurity, especially at the household level. And this always comes up when we have these conversations. South Africa produces enough food per capita. If you do a calorie per person calculation, we should be fine. But for many households, that simply isn't true. Families, caregivers sacrifice meals in order to feed children. Children go to bed hungry. And that is a very real problem that's contributing to the stunting rates. I think the actual number, is it 28% or is it 25%? That to me is less important. The emphasis that the research puts on the scale of the problem and the fact that it hasn't reduced significantly, that is where the conversation is interesting.
Sure. I mean, you raised some interesting points, particularly around what's been happening all this time. You say we haven't really moved the mark. It stayed fairly stationary, regardless of whether it's the 25 or 28%. Many people hear the term stunting and they may not have fully grasped those implications. Perhaps you could break that down a bit for our listeners and explain some of the long-term effects, particularly around child development and early learning. I think that's of course really front and center for those working with children and families.
Yeah, absolutely. So stunting, the definition is that a child who is stunted is short for their age, which means that they didn't reach their genetic potential in terms of their length or their height. And so we identify it by measuring a child, either a child who can't stand yet, so a baby we measure lying down, or a child who's able to stand independently we measure against a wall or some kind of stable, kind of perfectly 90-degree situation so that we have their accurate height. And then we also note their age at that moment when they are measured. And so these two pieces of information are required for us to find out where the child lies in relation to the growth standards, which is the definition of what we would consider normal or optimal growth for children who grow up in conditions without extreme poverty or environmental challenges, etc. So that's the definition of stunting. But, we don't really mind if children are short.
Sure.
That's not what stunting tells us,
Yes.
I think people, they hear short for age and they think, short means bad. That's not the case.
Yeah.
What stunting gives us insight into is, we call it a really good proxy indicator. So it allows us to understand the conditions under which a child is growing. And for stunting to manifest, or for a child to become stunted, you need inadequate nutrition, you don't need it, but you need adequate nutrition. But in the absence of adequate nutrition, as well as regular chronic infection, those are the kind of two big direct drivers of stunting. And so a child who's not eating a diet that has high enough diversity, enough food groups at a high enough frequency. So not just you've eaten a piece of carrot once in the last month, but are you regularly eating a food item with certain nutrients, etc. So it's a combination of those things. That's what makes up inadequate nutrition. And the chronic infection is often related to the conditions of the child's stomach. And so when a child does not have a healthy stomach lining, because of infection, their ability to absorb nutrients is affected. And that's where the infection and the dietary intake come together and result in poor growth. So what does this mean? Now we know what causes it, but what does it mean to be stunted? And we know from extensive research that's been done in South Africa and in many other countries that are comparable to South Africa, that typically kids who are short for their age at age 2, they don't do as well as their peers who were not stunted at age 2 when they're at school. So they are more likely to drop out or repeat grades. They then, as we know, dropout is a big driver of unemployment. If you don't complete school, that also puts you in a different kind of employment trajectory in South Africa. So you earn less than your peers. And then that's a kind of education and employment pathway. But there's also a medical kind of section of effects. And we know that stunting predisposes a child to developing things like non-communicable diseases. So these are your hypertension, diabetes, those kind of diseases. And it really, the ideal for every child that's born in South Africa, and I think this is, Jess, where you and I agree so much. It's like we want every child to have the best chance of a happy, fulfilled, successful life. And we just know that stunting doesn't create the environment for that individual child to thrive and reach their potential.
For sure. And the odds just are not in their favor because of the myriad of challenges that they are then up against, which you've so eloquently framed. So just to say, I think it's that thing of, we know that our communities are facing stresses and challenges and issues, and then stunting exacerbates the myriad of things they would then have to navigate throughout their life.
Yeah. And we know from the data that poorer communities have high rates of stunting. So this is a condition that tracks according to a household's income. And therefore, the poorest children are the most vulnerable and they need the most help. And that means help from the state. It means help from civil society organizations. It means help from communities. It means their parents need additional support. It really requires all of us to work together much more effectively in order to help those kids, because it is possible to defy your odds. Statistics are a predictor, but they don't, it's not. If you're somebody listening to this and you think, oh my word, I didn't have enough nutrition when I was a child and therefore now I will have this life. There are always things that we can do that can change our story. So it's not a fixed sentence, but it does mean that on average in populations, we can expect these kind of things to happen to people who've been identified with this particular condition.
Yeah, sure. And as you say, it's not the height for kind of the short factor. This is not about the physical, you are short and this is what we're after. We're seeing this child as a full person who will grow up into a fully functional adult and what their life could be like and the impact of that short trajectory or that shortness having on it. I'm so excited to speak about interventions. I'm having to hold myself back here from jumping straight into the solve, but I think it's so helpful to dive into the problem because so often I think the problem is washed with really strong statements and statistics that aren't always easily digestible. So we're like, oh, what do we do? But actually, when we realize that this is a problem, what the problem is, and that there are ways of tackling it. So yeah, it is helpful for framing it. We know that the first 1,000 days is significant to this conversation, and I'm curious that you haven't yet brought up breastfeeding. So that is something that I would love to introduce into this conversation, because I definitely think the first 1,000 days also gets a lot of talk time and yet isn't always understood from a nutrition perspective in terms of stunting. There are other reasons that it gets like lots of limelight, and we will definitely want to promote that, but maybe you could unpack a little bit around the first 1,000 days and highlight the nutritional component of the first 1,000 days.
Okay. So when I hear the term the first 1,000 days, I see two people. I see a pregnant person and I see a baby. And I think it's really important to hold both of those individuals equally and recognize the needs that are specific to each of those people. So the pregnant person has specific nutritional needs to support the fetus or the baby to develop optimally. And it's nutrition, but it's also mental health, it's also financial security, it's also a feeling of safety. So it's about providing an environment in which the pregnant person feels safe, nourished, and supported, and that leads to good outcomes for the baby. But the person herself also deserves those things just for herself, regardless of the fact that she's creating life or life is incubated in her body. So let's give that person due credit and due support. Then that person becomes
every pregnant mother ever says thank you.
The science is like, even if you're not somebody with empathy for pregnancy, the science is very clear that like well moms have well babies. Like it's very, very linked. Okay, so you're pregnant, you have a baby, then you become a person who we'd love for you to breastfeed, because breast milk is the best nutrition for your baby. I know breastfeeding is tricky, so I don't want to underplay that. But just from a nutrition perspective, it is the most incredible product. I don't really even want to call it a product, because it's like, but it should be marketed as a superfood. You know, it's this incredible, like in terms of the antibodies that it provides, the protein, the hydration, the nutrients. It's really a super product of your body that is attuned to the needs of your child. And so when you are that person who we call a lactating mother or a breastfeeding mum, you still need good nutrition for your own body to heal after pregnancy and labor and delivery, but also in order to make sure that your milk production is good. Interestingly, the way that evolution has protected this special relationship between a mom and a baby means that even when a mom's nutrition is not ideal, her body will prioritize the production of really good breast milk. So although we know from really amazing qualitative research that women who are hungry struggle with breastfeeding because they worry about things like transmitting their own hunger to their child. Those are like some of the really powerful quotes that have come from qualitative research. The biology or the makeup of the breast milk is still prioritized by the body.
Yes.
Yeah.
Yes.
And so things have to be really, really dire for breast milk quality to be severely affected. So maybe that's a little bit of comfort to know that your body knows, and millions of generations before you have benefited from breast milk, and therefore our design is such that breast milk will be good for a very long time, even when the mom is struggling. So, okay, now we've talked about what the mom needs and when she's pregnant and while she's breastfeeding. The baby, during pregnancy, the baby takes nutrients from the mother's body through the placenta. And when there are restrictions in terms of the nutrients that the developing baby is absorbing, we get something which we call intrauterine growth restriction, which basically just means the baby isn't growing quite, again, according to what we would consider the normal curve would be. And with intrauterine growth restriction, often the effect of that is that a baby is born with low birth weight, which means the baby weighs less than 2,500 grams or 2.5 kilograms. And a baby who is born with low birth weight is much more likely to be stunted. So that really draws the connection between why in the first 1,000 days there are two bodies that need each other. Well, the mother doesn't really need the baby, but she loves the baby. But the baby needs the mom to be as healthy as possible for their own growth and development, because the birth outcomes are also, in our statistical models, show us what is likely to happen, not guaranteed, but likely to happen in that child's life. And then the nutrients that the child consumes in the first 1,000 days, which up to age 6 months we hope is just breast milk, and that's the official guideline, and that's what everybody should be aiming for, then at 6 months you can start introducing solids. And I think this is where some children start to then leave the home environment and start to enter the early learning program. And so then that gets a little bit more complicated, because now there are more adults around who have to pay special attention to the needs of the child. It's not just that mom, baby, or baby grandma, or whoever is the adult who takes primary care of that baby. Now there's going to be somebody else too. And so now we really have to pivot a little bit from our side doing health promotion to make sure that the important information gets to all of the relevant adults. And I know sometimes it's not even adults, it's other siblings who aren't adults yet. But let's just say the caregivers now are more than just moms, and we need to make sure that they all have the information and they have tools to be able to implement that information in order to get good nutrition to kids.
Yeah, for sure. I mean, there's also the element of supply and demand that comes in with breastfeeding, and that child's ability to be close to their mom and by their mom and allowing that mother to establish a breastfeeding relationship is also really significant. And we're seeing with so many of our parent groups, mothers rushing back to work for all the reasons, and the struggle or feeling very pressured or stressed to stop breastfeeding quickly. And so, yeah, that supply and demand issue also comes in when children before 6 months are not being exclusively breastfed for a number of reasons. And it's a really hard conversation around keeping the baby as close as possible to the mother, because that's the baby's ecosystem, and it's the mother's opportunity to give the nutrients to her child, the optimal nutrients. So we're also seeing that on the ground so often. I have a question for you, or a follow-up question, linking to the solutions, because you're starting to hint to education. You're starting to hint to supportive factors for the mother, whether it's a young mum or an older mum. And I'd be curious to know what you think are some of before we get to what the solutions are, why are we still seeing these high rates of malnutrition, of stunting, and what is preventing us from scaling some of the solutions on the table at the moment? What do you think is the barrier to us kind of stepping into how do we solve this?
I think the reality is that many households in South Africa are still very poor. And we have done, well, I mean, I say we very lightly here, but like since democracy, lots of efforts have been put into place, systems have been built to improve the quality of life of ordinary South Africans. Our schooling system has changed from Bantu education to education for all. That's a fantastic change. Our welfare program now, the child support grant, is the biggest social protection program in Africa, and is a really important mechanism to provide families with some buffer to the really severe effects of poverty. But unfortunately, let's just talk about the child support grant quickly. It hasn't been increased in relation to inflation and food prices for many years. It's had quite arbitrary, 10 Rand every 6 months kind of increases. And we know anybody who's like,
thanks, but no thanks. That's not going to get me much.
No, the reality is that food is expensive, and particularly nutritious food is expensive. And so we know, again, from the evidence that the child support grant is not just spent on food, because to raise a child, you need more than food. You need, if you think about a baby, you need nappies, you need clothing, you need, if you think about, if it's just a mom and a baby, the mom needs to eat. So she probably needs to buy electricity to cook food for herself so that she's well nourished in order to have a simpler or an easier breastfeeding experience. So there are all these other costs, transport to get to the clinic, to get super important public health mechanisms like vaccination or immunization, deworming, vitamin A supplementation. These things are so important and are great programs, but the reality is to be poor in South Africa is expensive. And I really think that is at the core of why we haven't seen a drastic reduction in something like stunting, which is very much linked to the, as we said earlier, the dietary intake, the infection, the environment of the mom, the support for the mom. Those conditions are similarly stagnant, and that drives the continued high rate of stunting in South Africa.
Sure. I mean, we're hitting on some big things here, and I guess it really does land us in a position to acknowledge that South Africa is not in a great state, and we do have these cycles of poverty. But we do know that there are some solutions that have been popping up across the country, making impact, and we're seeing interesting evidence. So, could you share with us a little bit about the solutions that you've seen, success stories from across South Africa, any highlights that you think are significant game changers for tackling this problem?
There's that old adage or, saying that says, if you're not looking for the problem, you can't solve the problem. If you're not measuring it, it's not important, that kind of thing. If we are not measuring children's height regularly in order to identify whether or not they are stunted, we are flying blind. We are completely dependent on these every 10-year huge surveys that at the community level are not representative. The 2016 stunting or demographic and health survey in the Western Cape, where I do most of my work, the sample size was fewer than 100 children. That is not, if you're talking about scientific rigor and understanding local drivers, planning interventions, finding how these interventions that we know from the evidence work and implementing them locally to have an impact, we need better data. And the important thing is to do the growth monitoring regularly, the surveillance of the problem, in order to say, look, this is the state of the problem here, not the national average we're debating. Is it 28%? Is it 27%? That's irrelevant at a community level and in the lives of the children that are affected. So I would say measure it. And there are some incredible stories about organizations who have embedded community-based growth monitoring programs. The gold standard, I would say, is to use community health workers because they do home visits. And so when a child is at home, a community health worker will interact with them, measure them, and be able to refer them based on the information that they get from the measurement.
They also have, linked to the clinic. They also are resourced and are given the authority within a community setting to do what you've just said, to create that referral and link back to a clinic. So
absolutely.
Yeah.
Community health workers, but community health workers, they've got this incredible access to a household and to a family, but they also need support. So it's not good enough to just say community health workers will measure children and then we will solve the problem. We need to make sure that community health workers have the right equipment, are supervised, are empowered, really understand the problem, are accurate in their measurements. So it's not, let's just accept that it's a tricky one, but we know that is really powerful to do community-based growth monitoring through a community health worker program. That's ideal. in some parts of South Africa, there are no community health workers, or the ratio of the number of community health workers to the number of families is a little bit out. Or if you think about rural contexts, if a community health worker is supposed to check in, start a day at the clinic, and then walk miles, kilometers from that clinic, over hills, through rivers, etc., to get to households, that becomes a challenge. So then we've got to say, okay, wait a minute, where else can we find children? And often the answer is ECD centers. And so another way to do it is to say, or I would say a complementary way, ideally we're building a layered system where like either we're getting the kids at the house. If they're not at home, we're getting them at the creche. If they're not at the creche because they're slightly older, they're in the school system, etc. So we're really layering all these different mechanisms to get to reach children effectively. So I believe that ECD practitioners can also be trained to do growth monitoring, and there are great examples of that. Also, again, acknowledging that ECD practitioners are, I think, the unsung heroes of South Africa and already have a lot on their plate. So let's just also acknowledge that asking them to do this other thing on top of their already busy days, we should be sensitive to what that additional ask means for them practically. But especially in areas where we've got poor community health worker coverage, upskilling ECD practitioners, who often are the people who prepare food, feed children, understand the different ages and the needs. That's a great other avenue to get to measuring children in communities.
Yeah, I'm excited about what you're sharing because I think it's so practical. It's something we can physically do. It's something that will allow us to have an actual eye on the problem with tangible results. As you say, if we're not measuring it, we don't actually know what the problem is. And I think in some instances in communities, we may be surprised at what we find because we haven't had that level of monitoring or screening happening. And to have it at community level means that the communities themselves have agency to go and do something. Whereas when it's very high level data around national average, it becomes a big national problem. And sometimes that's a very slow solve. Whereas at community level, there are practical things we can do. And anyway, I'm very excited about this suggestion. Always in favor of a height chart for sure. And I'm excited to dial into that because I think it's also a scalable, it's something we can talk about at scale. It's something that's practical. I suppose it does cost something. And I think that is one of the barriers to this kind of measurement is that there is a cost involved, and it often involves a warm body, that's a person, a field worker, a community healthcare worker, somebody to physically go and do that measurement. And I think that is sometimes a barrier.
Can I quickly interrupt?
Yes, go for it.
I think there's also another hidden cost, which I think implementing a program like this often shows you over time, is that when you create awareness about a problem like stunting in a community and you convince your primary caregivers, your community health workers and your ECD practitioners that we need to measure this problem. And we have a beautiful referral system that means the child is we encourage the child to be taken to the clinic. If the clinic does not honor that level of buy-in of the person bringing the child to the clinic for intervention, then that risk of a trust dynamic, I think we have to be very careful about. We can't ignore the fact that it is expensive for many to take their kids to the clinic. They arrive with an expectation of some kind of intervention. And if it's not in the clinic's practice to measure the child, And they say they only, for example, take the child's weight, and the weight is fine, but we know the issue is with the height, and the kid goes home with nothing. No support. The parent doesn't feel validated for the effort that they've made to take their child. That risk of building agency and understanding of a problem, but then not having the expectation of that problem being addressed met, that's a serious challenge for me. And that means that those of us who work in civil society, who work alongside the state, have a responsibility to advocate to the state to make sure that those touch points where our referral systems meet the state system, that they are also aware and able to respond. And that's where the local relevance and the national advocacy conversation, that's where those two come together, and where it's super important for us to remind National Department of Health that while we are helping you identify the problem, we are also creating an expectation in communities that this problem will be addressed. And we don't have the budgets or the power to implement a national primary healthcare system intervention. But government does, and it's actually their job to do it. And we need to create that agency, but also demand that the system responds to the problem. And I think that's often a little bit hidden in the conversation when we're thinking about interventions. We're just like, well, if our target is to growth monitor 10,000 children and we've done that, we will say, oh, we've done our bit. But if we haven't thought about what comes next, then I don't think the measurement of those 10,000 children, we should be as excited about it as we are when we just meet the raw numbers. We really have to have a systems perspective on what those 10,000 children growth monitored means and where they land in the system.
Yes. Something that you've sparked in my mind as we speak about this is also around the use of the Road to Health book and how significant that is for mothers and parents and caregivers to be able to track over time, but also have that agency to also go and access services. Again, you need the buy-in from the clinic on the other side, and we're seeing that more and more on the community front. So I have one last question for you now that we've tackled some of the solves, thinking around the practicalities of measuring and monitoring. Could you give us your thoughts around one big shift you think needs to happen for South Africa's approach to change? We've spoken about government, civil society, we've spoken about advocacy. What is the thing in the next 5 years, if we could shift that, it would make real impact in terms of malnutrition in South Africa?
I like this question, but I also feel very challenged by it because I think we know that there's no silver bullet for solving a problem like stunting. There's no one thing that we just haven't discovered yet that suddenly is going to change everything. So it's tempting to say things like we know we've got this list of nutrition interventions, and if we improve the coverage of the top 10 interventions by 50%, then we can expect this kind of result. So that's one way of answering the question. I really believe that given the importance of the relationship between the mom and the baby, or the pregnant person and her developing baby, if we can fix the way in which we support pregnancy, we will benefit 2 lives through that intervention. And so I am a full convert of the plan to get a maternity support grant in place, because we know from the information we've got on the importance of the first 1,000 days, on cost benefit analysis of when in the life course of a human when do we invest and expect certain results? We know that early is best. And really for a mom and baby relationship, that early means during pregnancy. And we will spend less money as a country on things like remedial interventions during primary school. We will spend less on healthcare interventions, like a person who's got to live with hypertension or diabetes for their whole life. That simply is something that we can avoid that. And so I'm going to put my my weight behind the maternity support grant, because I really think that there's something sacred about the relationship between a mom and a baby, and that starts during pregnancy. And so we have to fix how we support pregnancy. And I think by giving more financial support, we are showing as a country that we value this time and we value the potential that those 9 months, or how, most people, 9 months.
Yeah. They matter.
That is a special time, and it matters.
Yeah.
Exactly.
Yeah.
And we want to make sure that it's a good time for mom and baby. And so that's where I'll end with my, there's a long list of interventions, but I really believe that can be a game changer.
Definitely. Sure. Well, there you have it, ladies and gentlemen. Anna-Marie Müller speaking on malnutrition and stunting. And yeah, what a gift to be able to dial deeper into these thoughts. I mean, I so appreciate how, clearly you're able to articulate what this is and how you've grappled with it over time. This is not your first beat around the bush, that's for sure. And I'm really excited to watch as you trailblaze the nutrition sector and link the systems that go with it. And I think for me the message that I'm hearing more and more is around this layered effect. We have to be collaborating, and we have to be seeing more than one solve happening at a time. So thanks for sharing. Could we tackle my limerick one more time?
Yes, you can.
Okay, I'll go first. Pick a picky pickle packed with peppy purple snacks. If you picky pickle pack lacks, then pick some plum peppers, pile them back. Okay, that was my best attempt.
Okay, well done, Jess. I'm gonna try and match you.
Thank you.
Okay, let's go.
Okay.
Pick a picky pickle packed with peppy purple snacks. If the picky pickle pack lacks, pick plum peppers, pile them back.
Yay. Thank you for joining us. And I'm looking forward to continuing this conversation more. I'm sure we'll have you back in due course. So thanks for sharing.
Yeah, no, I mean, let me just also add that I absolutely value your contribution in this space. Like neither of us are dietitians or technically nutrition people, but we come to this with our different perspectives, and that's where the magic happens. And so
for sure.
I also advocate for the nutrition space to be super inclusive, because that's where we're going to solve the problems. We've got to think in new ways, and that means more brains with different kinds of angles and twists. In order to get us to better solutions more quickly.
Some good stuff. I'm pumped. So thanks for sharing, and join us again.
Playtime.